I am Dr. Chiadi Ndumele. I am a cardiologist and an associate professor in the Department of Medicine at Johns Hopkins University.
And I'm Dr. Janani Rangaswami. And I'm a nephrologist. I'm a professor of medicine at the George Washington University School of Medicine. When patients progress to stage 2 CKM, this now encompasses patients with metabolic risk factors or kidney disease. So these would include patients with established hypertension, type 2 diabetes, metabolic syndrome, dyslipidemia, or chronic kidney disease. Now, talking about chronic kidney disease, Chadi, it is really important to point out that in the United States, 90% of patients with CKD don't know they have CKD. And even in those where it may be first detected, it isn't properly risk stratified because you actually need two elements. And when you put these two metrics together in a well established risk heat map, which has been pioneered by KDIGO, you can appropriately stratify patients. You can even show them where they are on this risk grid.
It's worth recognizing that there's this really powerful interplay between these stage 2 factors. So, obesity and diabetes and hypertension leading to CKD, CKD leading to worsening hypertension, metabolic syndrome within that leading to all of these factors and encompassing these factors. So, it's probably worth calling a little bit of attention to diabetes and this growing array of cardioprotective therapies, particularly the SGLT2 inhibitors and the GLP-1 receptor agonists. And, wanting to make sure that in those individuals who have certain comorbidities like CKD or who have very significant obesity or significant hyperglycemia, that we're emphasizing the use of these agents, GLP-1 receptor agonists to think about addressing weight and glycemia in a powerful way, SGLT2 inhibitors to think about addressing CKD.
Absolutely, Chiadi. And we now have a rich body, high level, evidence backed body of literature now supporting broad use of SGLT2 inhibitors in patients with chronic kidney disease, those with and without diabetes. In patients with a confluence of diabetes and CKD, another agent, finerenone, has also gathered a lot of attention. And now we have good data, both from the Fidelio DKD trial as well as cardiovascular outcomes in patients enrolled with diabetic kidney disease from Figaro and the pooled analyses of Fidelity, showing additional benefits on top of ROS inhibition.
We now have this increasing array of these therapies that affect multiple systems, right? Affecting the kidney and the heart and the metabolic outcomes, as well as, differing effects of these different agents.
Absolutely. And like you said, our staging system takes that qualitative angle and our risk prediction calculator, which will add that quantitative perspective as well. And I think it truly helps move the needle in terms of more precision in terms of that risk stratification and appropriate deployment of therapies.